everybody. I'm Basem Abd ElHamid, Head of Cardiology Department in Kubri Al-Ubba Military Hospital. Our lecture today is about essentials of atrial fibrillation, basics of rhythm rate management. We all know that atrial fibrillation is the most common sustained arrhythmia. It accounts for 1/3 of hospital admissions for cardiac rhythm disturbances. The worldwide age-adjusted prevalence of AF is estimated at equally 0.6% in men and about 0.4 in women, with a total 33 million. It may cause significant symptoms and impair both functional status and quality of life. Without therapeutic intervention, affected patients are at increased risk for mortality and morbidity through thromboembolic events and limiting symptoms. In the AF, the loss of regular and organized contraction of the left atrium, as well as the subsequent increase in ventricular lead, leads to both immediate and long-term adverse consequences like deterioration in hemodynamics, secondary to increased heart rate and loss of AV synchrony, and increased risk of stroke and other embolic events from left atrial thrombi, progressive dysfunction of the left atrium and left ventricle. What about the management? The 5 domains of integrated AF management include: the first is acute rate and rhythm control in the form of, for example, the beta blocker, the cardioversion, the aim of which is hemodynamic stability of the patient. The second line is management of precipitating factors, the lifestyle modification, treatment of underlying cardiovascular condition, the aim of which is cardiovascular risk reduction. And the third is assess the stroke risk by giving oral anticoagulation in patients at high risk for stroke, the aim of which is stroke prevention. The first 3 lines, the aim of them is improved life expectancy. Line of management is assist heart rate by rate control therapy to improve symptom and preservation of left ventricular function, and finally assist symptoms by using the antiarrhythmic drugs, the cardioversion, catheter ablation, and AF surgery to improve symptoms, the 2 last lines for improvement of quality of life and autonomy, social functioning. When to intervene, when it is needed to urgent involvement of specialized atrial fibrillation service when the patient is hemodynamically unstable, when uncontrolled heart rate, symptomatic bradycardia not amenable to reduction of rate control agents, in case of severe angina or worsening of left ventricular function, and last in the transient ischemic attack or stroke. The aim of management in the AF patients, the first one is prevention of complication, reduce symptoms like the palpitation, dyspnea, fatigue, and dizziness by using the antiarrhythmic, control of ventricular rate, and prevention of cardiovascular complications. Of course, in addition to rhythm control therapy by cardioversion, antiarrhythmic drug therapy, or ablation therapy. There is very important question: is rate more important than rhythm in treating atrial fibrillation? We all know that restoration of sinus rhythm will make the patient feels better, reduce the risk of emergency hospital admission and stroke, improve the ejection fraction, improve the exercise capacity, and finally improve the outcome. But rhythm control versus rate control in clinical outcomes in patients with atrial fibrillation, what trials said about that? Is it rhythm or rate control? The Orbit AF registry said that in adjusted analysis there were no statistical differences in clinical outcomes between rhythm control and rate control treated patients. However, rhythm control was associated with more cardiovascular hospitalization. So the conclusion of the Orbit AF, that among patients with AF, rhythm control was not superior to rate control strategy for outcomes of stroke, heart failure, or mortality, but was associated with more cardiovascular hospitalization. The second trial was a firm trial, which said there is no difference in all-cause mortality or stroke between rate control or rhythm control. The third one is the RACE trial, the rate control versus electrical cardiovascular trial. It said that rate control not inferior to rhythm control for prevention of cardiovascular mortality and morbidity composite endpoint. And the last one is the AF congestive heart failure trial. It said that in patients with ejection fraction less than 35, there was no difference in cardiovascular mortality, symptoms of congestive heart failure in the secondary outcomes, including death from any cause and worsening of heart failure between rate and rhythm groups. However, these studies primarily enrolled older patients, older than 65 years, with persistent AF who were mildly symptomatic. Thus, the results cannot be explorated to many subgroups of patients, including the younger patients, those with new first onset AF who may benefit from early cardioversion to sinus rhythm, patients with persistent AF who are highly symptomatic, and patients with significant systolic heart failure who have a hemodynamic benefit from the atrial kick. When to offer rate or rhythm control? It's a very important question. Who is the patient to start with, the rate control or rhythm control? The rate control should be initial approach in elderly patients with AF and minor symptoms, IHRA 1 guidelines. According to the guidelines, it's class 1. Rate control should be continued throughout a rhythm control approach to ensure adequate control of the ventricular rate during recurrences of AF, class 1. Regarding the rhythm control is recommended in patients with symptomatic AF more than IHRA 2 despite adequate rate control, class 1. Rhythm control in patients with AF and AF-related heart failure should be considered for improvement of symptoms, class 2A. Rhythm control as initial approach should be considered in young symptomatic patients in whom catheter ablation treatment has not been ruled out, class 2A. Rhythm control should be considered in patients with AF secondary to a trigger substrate that has been corrected, like the ischemia or hyperthyroidism, class 2A. And finally, of course, the patient preference. Factors may influence success of rhythm control is the long history of AF, the older patient, and we will see later why older age, more severe associated cardiovascular disease, other associated medical condition, and of course the enlarged left atrial size. Now we will talk about the heart rate control in AF. The ESC guidelines 2016 said that beta blockers, digoxin, diltiazem, or verapamil are recommended to control heart rate in patients with left ventricular ejection fraction equals or more than 40, class 1. And beta blocker and or digoxin are recommended to control the heart rate in AF patients with an ejection fraction less than 40 in class 1. The combination therapy comprising different rate controlling agent should be considered in single agent does not achieve the necessary heart rate target 2A in patients with hemodynamic instability or severely depressed left ventricular ejection fraction. Amiodarone may be considered for acute control of heart rate. Never in patients with permanent AF who were not attempt to restore sinus rhythm is planned. Antiarrhythmic drugs should not routinely be used for rate control. It's harmful for the patient. Arresting heart rate, our target is less than 110 beat per minute. Lennon rate control should be considered as the initial heart rate target for rate control therapy. And rhythm rather than rate control strategy should be considered as the preferred management in pre-excited AF and AF during pregnancy. Finally, the atrioventricular node ablation should be considered to control heart rate in patients unresponsive or intolerant to intensive rate and rhythm control therapy, accepting that those patients will become pacemaker dependent. This is a diagram shows the acute heart rate control in atrial fibrillation, when the ejection in the right side, when the ejection fraction is equals or more 40%, start with beta blockers or diltiazem or verapamil. Check the previous drug history of the patient, of course, to avoid concomitant administration. Our aim is less than 110 beat. If failed, add digoxin. Keep in mind to avoid bradycardia and to perform echocardiography to determine the further management and choice of maintenance therapy. Consider need for anticoagulation. Of course, I'm not talking about the anticoagulation, which is a very important entity because it is mentioned in a previous lectures. What about in case of the ejection fraction less than 40% or signs of congestive heart failure? Start with the smallest dose of beta blockers, or to achieve rate control, amiodarone is an option in patients with hemodynamic instability or severely reduced left ventricular ejection fraction. Also, our rate is less than 110 beat per minute. If not responsive, add digoxin. Regarding the AHA-ACC HRS guidelines in 2019, the AF complicating acute coronary syndrome, intravenous beta blockers are recommended to slow a rapid ventricular response to AF in patients with acute coronary syndrome who do not display heart failure, hemodynamic instability, or bronchospasm. It's class 1. Administration of amiodarone or digoxin may be considered to slow a rapid ventricular response in patients with acute coronary syndrome and AF associated with severe left ventricular dysfunction and hemodynamic instability. Number 3, administration of non-dihydropyridine calcium antagonist may be considered to slow rapid ventricular response in patients with acute coronary syndrome and AF, only in the absence of significant heart failure or hemodynamic instability. What about the long-term rate control? Rate control using beta blocker, non-dihydropyridine calcium channel blockers, digitalis, or combination is recommended in patients with paroxysmal, persistent, or permanent AF. Avoid the bradycardia. Class 1. Symptoms related to AF during activity should be adjusted to achieve a physiological chronotropic response and to avoid bradycardia. Class 1. In pre-excited AF, propafenone or amiodarone is preferred. Class 1. It is reasonable to initiate treatment with a lenient rate control protocol aimed at resting heart rate is less than 110. Stricter rate control strategy when symptoms persist or tachycardiomyopathy occur. Our aim that the resting heart rate is less than 80 during moderate exercise, less than 110, and 24 hours Holter monitor is recommended to assess safety. It is reasonable to achieve heart rate control by administration of durindarone 40 milligrams twice daily in non-permanent AF, except it's contraindicated in NIHA class 3 or 4 or unstable heart failure. In case of COPD, digoxin and small dose of selective beta-1 blocker is indicated. Digoxin indicated in patients with heart failure and LV dysfunction, and of course in sedentary inactive patients. Rate control may be achieved by administration by oral amiodarone when other measures are unsuccessful or contraindicated. It's class 2B. This is the long-term control in patients with atrial fibrillation. It is according to ejection fraction. If it is more than 40%, diltiazem, verapamil, or beta blocker, or digoxin. Add therapy to achieve target heart rate or if ongoing symptoms. Means if I started with diltiazem or verapamil and the patient is still complaining, symptomatic, or the heart rate is still high, add digoxin. If I started with a beta blocker, I can add digoxin. If I started with digoxin, of course, I can add diltiazem, verapamil, or of course, beta blocker. In case of ejection fraction less than 40%, start with beta blocker, small dose of beta blocker, or digoxin. If the patient is still symptomatic, add digoxin in case of beta blocker, or add beta blocker in case of starting with digoxin. These are the medical treatment drugs that are used to control the heart rate, including the beta blockers, the non-dihydropyridine calcium channel antagonist, the digitalis, and finally the amiodarone and dronedarone. Now we'll talk about the rhythm control therapy. Conversion of the AF, there are general recommendations according to the ESC guidelines. First, rhythm control therapy is indicated for symptom improvement in patients with AF class 1, management of cardiovascular risk factors, and avoidance of AF triggers should be pursued in patients on rhythm control therapy to facilitate maintenance of sinus rhythm. With the exception of AF associated with hemodynamic instability, the choice between the electrical and the pharmacological cardioversion should be guided the patient and physician preference, class 2A. What about the conversion? So, electrical cardioversion of the AF is recommended in patients with acute hemodynamic instability to restore the cardiac output. It's class 1. Cardioversion of AF, either electrical or pharmacological, is recommended in symptomatic patients with persistent or long-standing persistent AF as a part of rhythm control therapy. Class 1. Pre-treatment with amiodarone, flecainide, or epitolide, or propafenone should be considered to enhance success of electrical cardioversion and prevent recurrent AF. In patients with no history of ischemic or structural heart disease, flecainide, propafenone, vernacalant are recommended for pharmacological cardioversion of new-onset AF. In patients with no history of ischemic or structural heart disease, epitolide should be considered for pharmacological conversion of AF. In selected patients with recent onset of AF with no significant structural or ischemic heart disease, a single oral dose of flecainide or propafenone, the pill-in-pocket approach, should be considered for patients-led cardioversion following safety assessment, class 2A. In patients with ischemic and structural heart disease, amiodarone is recommended for cardioversion of AF class 1. Vercalant may be considered as an alternative to amiodarone for pharmacological conversion of AF in patients without hypotension, severe heart failure, or severe structural heart disease, especially the aortic stenosis class 2B. This is a diagram showing that in case of hemodynamic instability, go urgently to electrical cardioversion. If no hemodynamic instability, go to the patient choice and of course the physician choice, either the elective to do electrical cardioversion or pharmacological cardioversion. In case of pharmacological cardioversion, it is dependent on if there is no relevant structural heart disease, give intravenous flecainide, epitolide, propafenone, or vercalant, or pill-in-the-pocket flecainide or propafenone. In cases of coronary artery disease, moderate heart failure with reduced ejection fraction, or in case of heart failure with preserved ejection fraction, or in case of abnormal LVH, intravenous amiodarone or vernacalant, and in case of severe heart failure, significant aortic stenosis, intravenous amiodarone is the choice. What about in case of acute coronary syndrome, urgent direct current cardioversion of new onset AF in the setting of acute coronary syndrome is recommended for patients with hemodynamic compromise or ongoing ischemia or inadequate heart rate. Now we will talk about the long-term rhythm control principles. We should all know treatment is motivated by attempts to reduce the AF-related symptoms. Efficacy of antiarrhythmic drugs to maintain sinus rhythm is modest. Clinical successful antiarrhythmic drug therapy may reduce rather than eliminate recurrence of AF. If one antiarrhythmic drug fail, a clinically acceptable response may be achieved with another agent. Drug-induced proarrhythmia or extracardiac side effects are frequent. Take care when giving the long-term rhythm control. Safety, rather than the efficacy considerations, should primarily guide the choice of antiarrhythmic agent. Now we will talk about the antiarrhythmic drugs for long-term maintenance of sinus rhythm and prevention of recurrent of AF. The choice of AAD needs to be carefully evaluated, taking into account the presence of comorbidities, cardiovascular risk, and potential for serious proarrhythmia, extracardiac toxic effects, patient preference, and symptoms burden. Class 1. Dorindarone, flecainide, propafenone, sotalol are recommended for prevention of recurrent symptomatic AF in patients with normal left ventricular ejection fraction and without pathological left ventricular hypertrophy. Dorindarone is recommended for patients for prevention of recurrent symptomatic AF in patients with stable coronary artery disease without heart failure. Amiodarone is recommended for prevention of recurrent symptomatic AF in patients with heart failure. Amiodarone is more effective in preventing AF recurrence than other antiarrhythmic drugs, but take care by the extracardiac toxic effects are common and increase with time. For this reason, other antiarrhythmic drugs should be considered first. Patients on antiarrhythmic drugs therapy should be periodically evaluated to confirm their eligibility for treatment. ECG recording during the initiation of antiarrhythmic drug therapy should be considered to monitor heart rate, detect the QRS and QT interval prolongation, and the occurrence of AV block. Antiarrhythmic drug therapy is not recommended in patients with prolonged QT interval or those with significant sinoatrial nodal disease or AV node dysfunction who do not have functioning permanent pacemaker. Adding atrial pace bradycardia pacing to drug treatment that induces or exacerbates sinus node dysfunction should be considered to allow continuation of antiarrhythmic drugs therapy in patients whom AF ablation is declined or not indicated. Continuation of antiarrhythmic drug therapy beyond the planking period after AF ablation should be considered to maintain the sinus rhythm when recurrence seems likely. And this is about the long-term rhythm control. If no and minimal signs of structural heart disease or heart failure, it's patient choice to give pharmacological treatment like the flecainide, the propafenone, or sotalol or dorindarone, or to do catheter ablation. In patients with coronary artery disease, significant valvular heart disease, abnormal LVH, it is patient choice to do pharmacological treatment like the sotalol, amiodarone, or dorindarone, or to do catheter ablation. But in case of heart failure, amiodarone or catheter ablation. What about a failure of the long-term therapy to improve symptoms of AF? In case of failure of dorindarone, flecainide, or propafenone, or sotalol, it is the patient choice to do a catheter ablation or amiodarone, or to add another antiarrhythmic drug. In case of failure of amiodarone, it is hybrid therapy or catheter ablation. In case of failure of catheter ablation, do another catheter ablation or add another antiarrhythmic drug or hybrid therapy. Patient choice informed by AF team is the AF surgery, rate control, hybrid therapy. What about the non-antiarrhythmic drugs? ACE inhibitors and ARBs and beta blockers should be considered for prevention of new onset AF in patients with heart failure and reduced ejection fraction. Class 2A, ACE inhibitors and ARBs should be considered for prevention of new onset AF in patients with hypertension, particularly with LVH. and pre-treatment of ACE inhibitors or ARBs may be considered in patients with recurrent AF undergoing electrical cardioversion and receiving antiarrhythmic drug therapy 2B. It is inhibited to give ACE or ARBs, not recommended for secondary prevention of paroxysmal AF in patients with little or no underlying heart disease. We finished the pharmacological treatment to rate control. Now, what about the AV nodal ablation and modification? I know that there will be another lecture about the advanced rate control and rhythm control, but this is just a small hint about the AV nodal ablation and modification. When rate control cannot be controlled with pharmacological agents, when the AF cannot be prevented by antiarrhythmic therapy or in associated with intolerable side effects of the AF or the antiarrhythmic drugs, and direct catheter ablation or surgical ablation of AF is not indicated or has failed or rejected, this is the time of AV nodal ablation. In cases of permanent AF and indication of CRT, in cases of CRT non-responders in whom AF prevents effective biventricular stimulation and amiodarone is ineffective or contraindicated, although the symptomatic benefit of AV nodal ablation are clear, limitations include the persistent need for anticoagulation, loss of AV synchrony, and of course the lifelong pacemaker dependency. Of course, we talked about that one of the major important in rhythm, to control rhythm, is the age. What about the AF in elderly? We all know that the median age of patients with AF is about 75 years. 70% of individuals with AF are between 65 and 85. Increase the age will increase the prevalence of atrial fibrillation. Why AF in elderly? Because the myocardium experiences electrical and structural changes such as increased fibrosis, resulting in decreased ventricular compliance as a direct consequences of age. We know that with old age, the pharmacokinetics, pharmacodynamics, and pharmacogenetics in elderly are different. Age-related changes in pharmacokinetics and pharmacodynamics make the elderly more prone to development of adverse drug reactions, especially when incremental comorbidities are taken into account. Consequently, many elderly patients suffer from polypharmacy, making the drug interactions more likely. The altered pharmacokinetics of aging change the effect of absorption, bioavailability, distribution, and clearance of the drug. What about the challenges in management in the elderly? There are a comorbid illness like the hypertension, congestive heart failure, the LVH, the age-related degenerative changes in the cardiac conduction system like the sick sinus syndrome, the tachycardia bradycardia syndrome. Also the age-related pharmacologic and pharmacodynamic changes in the antiarrhythmic drug, the increase the predilation of side effects and proarrhythmia. So here, return to the AV nodal ablation again. What about the AV nodal ablation in elderly patient? It gives us the avoidance of polypharmacy in population with several comorbidities and medication. It decreases the risk of drug-drug interactions. Greater incidence of hepatic and renal insufficiency increase the risk of drug toxicity, so AV nodal ablation is better. Side effects of antiarrhythmics such as bradycardia, orthostatic hypotension, urinary retention, and falls is greater. Permanent safe solution for controlling rate in AF. Low incidence of repeat procedure compared to PVI, which means pulmonary vein isolation procedures. Elderly patients commonly have long-standing AF with atrial dilatation, hence they are poorly candidate for BVI procedure and possibility of improvement in cognitive symptoms, but we will be dependent on pacemaker. The conclusion, the incidence and prevalence of AF increases with age. Rate control strategy were recommended in most guidelines. AVN ablation plus pacemaker should be a solution for rate control complication. Whether AV node ablation is better than pulmonary vein isolation is elderly needs to be evaluated in more randomized clinical trials. And what about AF during the pregnancy? Electrical cardioversion can be performed safely at all stages of pregnancy and is recommended in patients who are hemodynamically unstable due to AF and whether the risk of ongoing AF is considered high for the mother or the fetus. It's safe. Give DC shock. Anticoagulation is recommended in pregnant patients with AF at risk of stroke to minimize the teratogenic effect and risk and intrauterine bleeding. Dose adjustment heparin is recommended during the first trimester of the pregnancy and in the second and the 2 and 4th week before delivery. Vitamin K antagonist or heparin can be used in the remaining parts of pregnancy. Never use the NOACs, should be avoided in pregnancy and in women planning to be pregnant. And thank you.